Hi everyone, welcome to our presentation on the prevalence of right-sided infective endocarditis in intravenous drug users. My name is Erin.
My name is Natalie.
My name's Ashley.
So to start off, we thought we'd take you guys through a little case study. We came across this at one of our clinical sites. This is a 50-year-old female who has a history of IV drug use. She already has a bioprosthetic tricuspid valve and was treated with IV antibiotics. She was scanned twice, first on April 22nd. So as you can see, the vegetation's on the tricuspid valve. And she had a follow-up scan on May 5th. So as you can see, the vegetation is much smaller. And there's just a little residual vegetation left. So we chose to show you this case just to demonstrate the relevance of this in our careers as ecotechs.
To introduce our topic, I'll start with defining infective endocarditis. IE is a bacterial infection of the heart valves or endocardium. S. aureus is the main organism found in up to 74% of cases. Echocardiography plays a key role in diagnosing infective endocarditis. Right-sided infective endocarditis is most common in intravenous drug users. And our purpose is to evaluate and summarize the current research on right side, IE, in IVDU and identify any gaps in care. As for our methods, we primarily use a variety of databases, peer-reviewed journal articles, BCIT lecture notes, and we searched key terms such as infective endocarditis, intravenous drug users, right-sided, prevalence, treatment, opioid, and epidemic.
So we'll first start off with prevalence. The graph on the left here shows that there's a direct correlation between the rate of opioid overdose deaths and the number of cases of infective endocarditis in intravenous drug users. I put a couple of stats up here. One study found that specifically IV drug use was shown to be a predisposing factor in just under 1/3 of right-sided IE cases in a literature review. This represents the single largest risk factor identified in right-sided IE. The overall risk of IE being nearly tenfold greater in the IVDU population compared with the general population highlights the need for efforts to treat substance abuse. And infective endocarditis accounts for approximately 5 to 20% of possible admissions in the IVDU population. So we just said that it was more prevalent in this population, but why? So the graph on the right here is just a good summary of risk factors. In addition to that, they may also have an increased skin colonization with S. aureus, as well as they may have damaged nasal mucosa and skin, which increases colonization with S. aureus. Impurities of substance being injected. Oftentimes, there are added substances to drugs that make drugs more profitable. However, these are impure, which can cause damage to the endocardium over time. The fact that they are choosing to inject these intravenously when puncturing the skin provides a direct route for bacteria to go through the heart. And eventually, over time, this damage to the endocardium and tricuspid valve serve as a good place for bacteria to grow and colonize. The table on the bottom just describes some other risk factors for infective endocarditis. These combined with any of the above puts them at a greater risk for developing this infection. Through our studies, we found that it was a lot more prevalent on the right side than the left, and we wanted to know why. There are only a few theories that we came across. One, that the right-sided valves act as filters for the impurities, specifically in the drugs that are impure. And the tricuspid valve and the right side is the first place the blood enters into the heart. Right-sided infective endocarditis with tricuspid valve involvement can be seen in as many as 70% of cases.
The clinical manifestations in an infective endocarditis patient include vegetations, which you can see on the top right photo, valvular regurgitation, osseous nodes, which is shown in the bottom photo, raw spots, embolic events, fever, heart failure symptoms such as dyspnea, orthopnea, cough, flu-like symptoms such as fatigue, chills, sweat, nausea, and weight loss, and lastly, chest pain, abdominal pain, or back pain. The diagnosis for infective endocarditis is based on the modified Duke criteria. This criteria consists of major criteria, which is 1, a positive blood culture for typical endocarditis organisms, 2, evidence of endocardial involvement, and 3, a positive echocardiogram of IE. The minor criteria consists of a predisposing heart condition or injection drug use, fever, vascular phenomenon, immunologic phenomena, and microbiological evidence. To be diagnosed with infective endocarditis, you must have 2 major criteria and 0 minor criteria, or 1 major criteria and 3 minor criteria, or 0 major criteria and 5 minor criteria. Our role of echo is to primarily look for vegetations on the valves. To do so, we will assess all valves in zoom mode, use high transducer frequency, place the focal zone at the level of the valve, and angle and tilt the transducer in all possible views. There are a few complications that can arise as a result of infective endocarditis. The first being an abscess, which is shown on the top photo there. Other complications include prosthetic valve dehiscence, pseudoaneurysms, fistula, leaflet perforation, chordal rupture, which is seen in the bottom image, and also valve aneurysm.
Next, I'm going to be talking about the treatment and readmission for infective endocarditis. So the considerations involved in the treatment of IE in intravenous drug users poses a significant challenge and ethical dilemma in healthcare providers when deciding treatment. IV antibiotic therapy continues to be the most successful therapy. However, surgery to treat the affected valve is considered. In the case of failed antibiotic therapy, urgent complications, or acute heart failure. As outlined on the table on the right are some surgical interventions for infective endocarditis. Surgical risk factors for intravenous drug users include being less compliant to post-surgical medical treatment, having higher rates of readmission and reoperation, as well as poor long-term clinical outcomes. This image shows a graphical representation of the number of IVDU readmitted with infective endocarditis compared to non-IVDU over a period of 180 days. And the readmission for IE proves to be significantly higher in IVDU as a result of continued drug use post-treatment. This is the most significant contraindication, making healthcare providers less inclined to operate despite some patients having very successful long-term post-surgical outcomes. Due to the contraindications present for intravenous drug users, it is a concern that prolonged delay in surgical treatment could also be creating adverse long-term outcomes for these patients and presents a gap in the current research. These findings outline the need for healthcare teams to provide timely substance abuse therapy in an attempt to ultimately reduce the rate of reinfection. So next, I'm just going to be talking about the prevention of readmission for infective endocarditis. So the image on the left compares the curves of 4 clinical outcomes between this population and non-intravenous drug users, including overall death, valve reinfection, valve reoperation, and valve-related complications, which are all considerably higher for intravenous drug users with the exception of overall death. The integration of medical, surgical, and psychiatric and addictions care, as well as social support following hospital discharge, can provide patients with the opportunity for improved long-term outcomes. Willingness of patients to actively participate in therapy, as well as continually follow up with healthcare providers, does present a challenge in long-term care. However, intensive rehabilitation programs started during hospitalization have reported with reasonable success rates in treating some patients' substance use disorders. Some harm reduction methods include naloxone kits, supervised injection facilities, overdose prevention programs, and medication for opioid use disorder. And they have proved to significantly reduce the overall rate of mortality in intravenous drug users. Hospitalization for infective endocarditis can provide a good opportunity for IVDU to begin addiction therapy. However, more efforts to address the opioid epidemic could prove even more beneficial in reducing the overall rate of right-sided IE. More studies regarding the rate of right-sided IE in relation to comprehensive addictions therapy are required in order to prove this as an effective method of treatment. And in addition, more attention must be focused on treating underlying drug addictions to remove any doubt of long-term postoperative success, and also allow intravenous drug users with severe IE to get the care they need without being subject to contraindication. So in conclusion, the rate of right-sided IE in IVDU and readmission post-treatment is alarmingly high. By using a more holistic approach to treatment, intravenous drug users can be provided with all aspects of treatment necessary to significantly improve long-term outcomes and reduce the rate of readmission. Echocardiography plays a key role in diagnosing IE, and as technologists, we can work to provide a safe environment for patients and take a thorough history as well as follow up on previous exams to ensure best practice. Although treatment for substance abuse is likely to reduce the rate of right-sided IE, it's unclear if this is truly the case, and more research is required to confirm this theory. Additionally, it is of concern that due to the contraindications present for IVDU, the prolonged delay in surgical treatment of IE could also be creating adverse long-term outcomes. And this concludes our presentation. Thank you guys for listening, and does anyone have any questions?